So it's James Harty again as a second plenary lecture, Common Errors in ACL Surgery.
Okay, so what do you do when your ACL fails, and what are the things to avoid to make sure that your ACL doesn't fail? Because the biggest mistake is probably something that was done in the first surgery. And if you don't recognize what your mistakes are, you don't know how to improve them. ACL failures will come because of three different problems. They will come because of instability, they will come because of stiffness, and they will come because of pain. And typically, they will come back with one of the three problems. When you talk about instability in ACLs, they can come because of an abnormal mechanical load. So it can be just simply, no matter what, the patient has put that knee through such a level of force that it re-ruptures. And if you go back and look at it, there's nothing technically you have done wrong. But it's really rare that you see these. You will get the odd patient who does their rehabilitation too quickly, who rushes, and you need to be careful with these patients that they understand that they can't rush before they do these cases. For my patients, it's a minimum of 1 year before I allow them back to sport. The biggest mistake that you will see is non-anatomical tunnel placement. Putting the femoral tunnel to anterior, putting the femoral tunnel to posterior, putting the femoral tunnel to vertical, or too medial or lateral in the tibial tunnel. So the biggest, most common mistake is tunnel placement. And I see these cases all the time, and for me they're an easy revision. An easy revision because all I have to do is put the tunnel in the right place and the patient is happy. Frequently misdiagnosed collateral injuries, people missing posterolateral corner injuries, people missing posterior cruciate ligament injuries or medial collateral ligament injuries. And then you've got failure of the graft fixation. So you've got to be very careful when you do these cases that you make sure that you fix them adequately. If you've used the wrong type of fixation, if you haven't thought about what you're doing, if your tunnel is too big and then your graft hasn't got good interference fit, it's not going to grow in and get stable for you. Failure of the graft tension, failure of the graft isometry. So you haven't put that graft in correctly. You've left that knee too tight. You've put it in too much flexion, particularly if you put in a PTB graft. They can't get it out into extension and then they fail. Then you can have other problems like poor graft selection, graft incorporation, or failure due to infection. If you get stiffness, typically that'll happen because they didn't get adequate rehab. When I do my ACLs, I always see the patient at day 10 because I take my clips out and I check my wounds myself. Because at day 10, the patient will have either started to rehabilitate well or they'll have to rehabilitate poorly. And frequently what happens is the surgeon does the surgery, he hands them off to the physiotherapist, and then he sees the patient at 6 weeks. If you see them at 6 weeks, they've gone already a substantial long way along the road of rehab, and they have already started to get a fixed flexion deformity, and they've already started to get a stiff knee, and it's really difficult to get them out of that. So for me, I always see these patients at around 10 days so that I can avoid all these problems and explain to the patient very carefully what I expect them to do. I've explained it in this hospital, but I explain it again 10 days later, and I find that by doing that, I avoid these problems. Your stiffness then could come from poor surgical technique. If you do your surgery too acutely, people always ask me, well, this patient has turned up with a very sore ACL, will you do their surgery now? It's very rare that I operate acutely on an ACL. It's really only in certain very high-level elite surgery patients, and I will only acutely operate on an ACL when I think that is a happy knee. You will get some patients and they will say, oh, I just tore my ACL by running. I didn't even know I tore it. My knee didn't even swell up. I didn't have a problem. That knee has full range of motion from the start. Okay, well, that's the patient you can operate on. If the patient is any other way restricted in their range of motion, has got significant swelling, you should wait until that settles down. Infection is your biggest problem. You've got to be aware of this coming in very early and be watching out for it at a very acute phase. And then complex regional pain syndrome, synovitis and hematoma. These are very rare things. I don't see these in my practice on a routine basis. What about pain? Well, some patients will get patellofemoral pain, and a lot of patients will get a bit more patellofemoral pain if you're too aggressive taking out the retropatellar fat pad. I'm very selective in how much of the fat pad I take. If you take the entire fat pad, that patient's kneecap will click and they will tell you that they get pain in their kneecap afterwards. The fat pad does have a role in reducing down patellofemoral pain and discomfort afterwards. You'll get donor site pain from the patellar tendon or from the hamstrings. Then you may have some arthritis, residual meniscal tears, neuroma, complex regional pain syndromes. So they're the most recent causes. The most important thing when you're doing your ACL to avoid a complication is that you examine the patient and you do patient selection. All of these patients I always check for hyperlaxity, hyperinstability, because if you don't know about this before you do the case, then you don't know whether you need to do a lateral stabilization on them also. It's very important that you evaluate their radiology, not just their MRI scan. There's a tendency to just look at the MRI scan and say, well, on the MRI scan, the ACL is gone. But these patients, you need to be sure that they don't have an increased tibial slope. You can see in these cases, they've got really hyperextension, they have significant tibial slope, and these patients have a very high risk of failure, and some of these patients will need an osteotomy to correct it. You should preoperatively evaluate the anterolateral ligament, and you should be looking for the edema along the lateral side of the tibia over the iliotibial band, looking for the avulsion of the iliotibial band or the anterior anterolateral ligament. It is something that I look for in every case. You need to make sure that you're not going to miss a posterolateral corner injury. And sometimes these are not reported correctly on the MRI scan. And every case of ACL that I operate on, I review the imaging myself. These are not cases where you should be relying on a report. You should be reviewing the imaging to make sure that the posterolateral corner, the lateral collateral ligament are intact, the medial collateral ligament is intact. On the pre-op evaluation, you should be looking at the lateral femoral condyle to see have you got a big notch on the lateral femoral condyle, because that's going to tell me that this patient has a very, very high risk of pivot. If you're going to see these edema and on the lateral side, you're looking for the lateral collateral ligament. The other biggest cause of failure of ACLs is graft diameter. And for me, every time I do, the biggest cause for that will be in patients who you do hamstring ACLs. Some people will only use a 4-strand hamstring ACL. They'll take a small hamstring ACL of a small woman, they'll put a 4-strand graft in, and they'll say, well, she's a small girl, she's got a 6mm graft, that'll be fine. It's very clear in the literature that grafts of 8mm or less will fail, and that is regardless of whether you're male or female. The size of the graft is really important, and you should be able to triple your grafts if you're using hamstring grafts to make sure you get adequate PTB grafts. One of the reasons why I started doing quadriceps grafts was because I get a more reliable graft for a quadriceps graft in an ACL reconstruction for females than I do if I go to get their hamstrings, because frequently by the time you've harvested the hamstring, you've got it out, it's already too small, you're committed. And then you say, well, I can't double it, I can't triple it, I can't get enough graft. So a more reliable graft for small women is a quadriceps graft. If you're going to use a graft from the hamstrings, I strongly recommend you use this graft harvester. This is a closed graft harvester. It's a Linvatec graft harvester. This does not resect the tendon too short, and that's a mistake that some people make when they use the standard open harvesters. Every time I use this harvester, I can get an 8, 9, 10 minimum size graft. So being very careful at what graft harvester you use is really important. Femoral tunnel is really, really important. You've got to make sure that you inspect your tunnel before you pull your graft up. You need to be sure that your graft is in exactly the right place, because this is the biggest mistake you're going to make and the biggest reason why you fail. You need to make sure you've got an adequate posterior wall, that you haven't blown out the lateral femoral condyle, that you see that you've got if you're going to use a suspension fixation device, that you've got a double tunnel and that you have fixation for your button on the lateral side. A lot of people don't recognize they blow out the tunnel, and suddenly they see this x-ray and they go, oh bloody hell, what do I do now? It's too late. It's too late. You should have thought about this beforehand, and you should have inspected the graft, and you should make sure you have a minimum of 2mm behind if you're going to put a screw in the femoral tunnel. Here's another mistake. You can see the femoral tunnel is far too anterior, far too superior. This is going to fail no matter what you do. Here's another femoral tunnel with a vertical tunnel. This is not going to control rotatory instability. You examine this patient with your Lachman's test. Oh, it feels okay, it's fine. But this patient has a massive rotatory instability. They will turn to you and they'll say, it was never right, doctor. From the very first day that you operated on me, I was unhappy. It doesn't feel stable now. Here's the other thing with the femoral tunnel. If you start to try and put it back, but you don't put it back far enough, the graft still sits up. And you need to make sure that when you put in your button and your endo button, you need to make sure that that button is sitting down far enough, number one, and you can see it flipped. And you can be sure, if you're not careful, this is what you'll find. You'll find your button back down through the femoral tunnel, and you'll have failed your ACL. So making sure that your button fits through and it sits and you know exactly where it is and it's in the correct position. Similarly, you need to be sure that you put your tibial tunnel in the right position, because if your tibial tunnel isn't exactly correct, you are going to have a problem. You're going to have impingement on your femoral notch. You're going to have an ACL that will fail very quickly. And a very simple trick is to put your wire through and then put the knee in extension before you do this. Put the wire through, put the knee in extension, and see can your wire go directly up through Blumensatz's line. If you have impingement with your wire before you drill your tunnel, well then you know you're going to have a problem. So just put the wire in, and if it doesn't impinge, well then you're fine. But if it does impinge, you need to correct your wire position. Here you can see tibial tunnel that was too far. You've got the graft starting to impinge, and here's your simple trick. You just put your wire up underneath the Blumensatz's line, and there you go. You can get it to sit, and you know your tibial tunnel is in the correct position. It takes 2 seconds, literally 2 seconds. Okay. When you're revising these cases, you need to look for all these tunnel evaluation. You need to be able to see, if you're having to revise these cases, where the tunnel is. You need to be able to see where the femoral tunnel is. You need to be able to examine where the tibial tunnel is. Sometimes in these cases, if I have to revise them, I use... Out again. Your concern is in pediatrics, if you put a screw across the physis, then they can get growth arrest when you do that. And that's when you most commonly see these injuries. It's in pediatric cases. But in these pediatric cases now, for the last number of years, what I use is a bioresorbable screw. Maybe one like I would fix with an osteochondral defect in the femur, and I put that on, and then I don't have to take that off. It's usually a short screw. You can use maybe about a 20 millimeter screw, and then you don't cross the physis, and then you're fixed.
That is a good option. What you say, Professor Masood?
I use mini arthrotomy because in my experience while I was doing an SHO job, and my consultants done a few times arthroscopic, but it took about 2.5 hours because there is a lot of bleeding at that time. So I started doing mini arthrotomy, as Professor James is saying. So my feeling is it's the better option, and I don't use bioabsorbable screws. I use a 3.5 screw, and I take it off after 3-4 months time.
After 3-4 months. So this is the reason that I avoid the screw. James said it is a good option if we have.
But screw taking takes about 10-15 minutes. It's only because you do under X-ray control.
That's good.
All right. Thank you.
Thank you. Any question?
Amir, I have fixed them with retrograde Herbert screws. You do scope, you reduce, you clean the crater, you reduce, and retrograde wires like you're passing spinal needles, and you pass Herbert screws. 2 mm, 20 mm, 2 mm dia, 20 mm length, or sometimes 24 mm length.
From the
problem is only if the
tibial side to the
retrograde. Yes, you don't have to open the joint.
I would like to make a comment.
Yes, please.
I found this technique very useful in cases when we have a combination at this bony piece, and this technique is very useful because in cases of combination, you are not able to fix those small pieces with a screw or whatever the device you're using. So this technique is quite useful, and I think
as I told, everyone surgeons have a different choices. There are different choices. So in buffet, we can take anything.